Welcome to our conversation on viral hepatitis, health disparities and care, a collaboration with the Centers for Disease Control and Prevention, otherwise known as CDC. This program is made possible with the generous support of our sponsors and partners, Mallinckrodt, Hepatitis B Foundation, Boston Healthcare for the Homeless Program, and Public Health Management Corporation. Thank you for your continued support. Please take a quick moment to review this disclaimer, as this program will be recorded and uploaded to our YouTube channel. As I mentioned, this program will be recorded and made available for on-demand viewing. And to ask a question, please go to our via messaging, click on the Q&A feature and type in your question. We will make every effort to ask all questions during the Q&A session. And please make sure to engage with us on Facebook, Instagram, and Twitter throughout the program and afterwards using the hashtag ALFConvo. Again, ALFConvo. Now to introduce our speakers, so exciting. Dr. Patel leads the Strategy and Implementation Unit in the Division of Viral Hepatitis at the U.S. Centers for Disease Control and Prevention. Dr. Patel and her unit leads select activities to accelerate progress toward hepatitis C elimination, including initiatives focused on people who inject drugs, American Indians, Alaska Natives, and other populations disproportionately impacted by hepatitis C. Kate is the Deputy Director of Public Health at the Hepatitis B Foundation and Director of Hep B United, a national coalition dedicated to reducing the health disparities associated with hepatitis B. Kate manages strategic planning, capacity building, training, technical assistance, and grant programs for Hepatitis B United. Marguerite is the Director of HCV Services at Boston Healthcare for the Homeless Program. She developed, implemented, and currently oversees a primary care-based hepatitis C treatment program, which has treated over 1,000 individuals and participates in HCV education, treatment, advocacy, and policy planning at local, state, and national levels. And Sabrina is the Public Health Management Director for Community-Based Outreach Programs for Public Health Management Corporation, which is a nonprofit public health institute that creates and sustains healthier communities. She oversees a community-based program that provides a 3-part viral hepatitis education, screening, outreach, and linkage to care services for community members throughout Philadelphia. Wow, we have some incredible speakers this afternoon, don't we? Well, we will begin with a presentation by Dr. Patel, and then we will have all of our speakers back together to discuss what their organizations are doing to combat, raise awareness, and educate.
I'd like to thank the American Liver Foundation
on viral
for
hepatitis.
This presentation and forum and for facilitating this conversation on this extremely timely and important topic. For this presentation, I will be focusing on the hepatitis C epidemic as a framework for discussion. However, CDC's interests in addressing disparities and eliminating viral hepatitis extend to all of the viral hepatitis. I thought I would start with a little bit of basic background information. Hepatitis C is a bloodborne virus that is spread when an uninfected person comes into contact with blood or body fluids from someone who is infected with the virus. Most often this happens by sharing equipment used to inject drugs. And less often it can happen by a spread from mother to child and sexually. Acute hepatitis C infection develops when someone is first infected. Often these individuals have mild symptoms or no symptoms, and more than half will progress to chronic infection, which can lead to severe liver damage, liver cancer, and even death if left untreated. Hepatitis C can be diagnosed with a simple blood test and is curable with a short course of direct-acting antiviral medications. In spite of this, we are seeing new cases of this preventable disease increasing. I'd like to spend a little bit of time talking about national trends in hepatitis C in the epidemic. Viral hepatitis has an extremely substantial public health burden. with an estimated 2.4 million people who are infected with hepatitis C. About 40% of these individuals living with hepatitis C haven't been diagnosed and remain unaware that they are infected, precluding them from accessing care or treatment. Not only are these numbers staggering, but new infections are on the rise and represent a major cause of morbidity and mortality. Also, there are substantial health inequities, which we will be discussing today. These are national surveillance data for cases of acute hepatitis C reported during 2003 to 2018. As you can see from the graph, rates of acute hepatitis C are rising, particularly in persons aged 20 to 29 years old, shown in the blue line, and in persons aged 30 to 39 years of age, shown by the green line. Among reported cases of acute hepatitis C, risk factor information is available for only about 51%. Of these cases for whom we have risk factor information, 72% reported a history of injection drug use, making it the most commonly reported risk factor. It is followed by multiple sex partners as the next most commonly reported risk factor of 32%. On this slide, we see that states with the highest rates of acute hepatitis C are shown in darker shades of teal. The lighter green shades indicate lower rates of acute hepatitis C, and the gray color represents no data available. Areas with high rates of hepatitis C tend to also be those regions most impacted by the nation's opioid crisis. This further supports the connection between these two epidemics or syndemics and variability of burden by geographic area. This graph shows reported rates of acute hepatitis C by race and ethnicity. Alaska Natives and American Indians had by far the highest rate among all racial and ethnic groups. Also importantly, the rates among many of these groups are increasing. This slide has a lot of information on it, so I've highlighted just a few key points. The table describes hepatitis C mortality data by race and ethnicity, and I've added some text to the side of the table to demonstrate how certain groups compare to non-Hispanic white persons. After adjusting for age, the rate of death from hepatitis C among non-Hispanic Black persons is about twice that among those who are non-Hispanic white. Hispanic persons also have a higher rate of death from hepatitis C compared to non-Hispanic white persons, at about 1.4 times the rate. And American Indians and Alaska Native persons have a death rate from hepatitis C that is 3 times that among non-Hispanic white persons. Statistics such as these reinforce the importance and immediate need for increased hepatitis C testing and linkage to treatment, particularly in disproportionately impacted populations. To recap a few points already raised, awareness of hepatitis C still lags. Only about 61% of people with hepatitis C between 2015 and 2018 were aware of their infection. 2018 marked a decade of increases in new hepatitis C infections among people in their 20s and 30s, and a simple blood test is needed to test for hepatitis C. We are actively working to raise awareness around who should get tested. CDC recommends testing for every adult over the age of 17 at least once in their lifetime, for every pregnant woman, regardless of age, with every pregnancy, and for everyone with risk factors regularly. Here are the expanded categories of screening for hepatitis C. Again, we recommend hepatitis C screening at least once in a lifetime for all adults aged 18 years and over, for all pregnant women, regardless of age, during each pregnancy, and for any person who requests it, regardless of the reason that they request it, as well as routine periodic testing for persons with ongoing risk factors, and screening of individuals is still recommended for persons who have recognized conditions or exposures to hepatitis C, including persons with HIV, persons who ever injected drugs or shared meals, persons with selected medical conditions that put them at risk for acquiring hepatitis C, such as having kidney disease that requires dialysis, prior recipients of transfusions or organ transplants, and persons who have select healthcare or other related exposures, and children born to mothers with hepatitis C virus infection. Lastly, I'd like to turn to strategic things. This table is from the HHS National Viral Hepatitis Strategic Plan. CDC and other agencies in the Department of Health and Human Services use this as a guide when planning programs and prioritizing research and prevention initiatives to ensure our work is reaching the people most impacted by viral hepatitis. Starting with hepatitis C at the bottom, you can see the groups most impacted by acute hepatitis C are people who inject drugs and American Indians and Alaska Natives. Those who are most impacted by chronic hepatitis C again include people who inject drugs, non-Hispanic Black persons, people who were born during 1945 to 1965, and those individuals who are most impacted by death from hepatitis C, and people living with HIV are the other group that are most impacted by chronic hepatitis C. Those who are most impacted by deaths from hepatitis C are American Indians and Alaska Native persons, non-Hispanic Black persons, and those people who were born during 1945 and 1965. You can also see that there are overlaps with other viral hepatitis. So for example, people who inject drugs and people who use drugs are heavily impacted by hepatitis A infections and acute hepatitis B infections. And non-Hispanic Black persons also have a disproportionate burden of chronic hepatitis B and deaths from hepatitis B infection. The Division of Viral Hepatitis at the Centers for Disease Control and Prevention strategic plans has 4 goals. The first 2 aim to reduce new infections and to reduce viral hepatitis-related morbidity and mortality, which carry forward the program's work from previous strategic plans. The last 2 include areas of critical expansion to reduce viral hepatitis-related disparities and establish comprehensive national viral hepatitis surveillance. Each goal has objectives under it with corresponding strategies. For reducing disparities, our objectives include increasing the utilization of services to prevent hepatitis B and hepatitis C among people who inject drugs, and increasing testing and linkage to care to reduce racial and ethnic disparities in hepatitis B and C infections and related outcomes. To summarize, there are 2.4 million people who are estimated to be living with hepatitis C in the United States. Most of these individuals are unaware of their infection status. If untreated, up to 40% will die of an HCV-related condition. The nation is experiencing increasing numbers of new HCV infections, which will have substantial downstream effects if unaddressed, particularly given the young age groups that are most heavily impacted by acute infections. These infections disproportionately affect certain racial and ethnic minority groups, and reducing disparities is a CDC priority and essential to achieving viral hepatitis A national goals. I'd like to express my special thanks to Dr. Mona Deshani, who prepared most of these slides, and everyone else who assisted on this slide, and thank you very much for your attention.
Thank you so much, Dr. Patel. That was very informative, and I love the last few slides in regards to the CDC's goals in regards to this. Now we're going to bring back our panel, bring our speakers back on camera. Thank you. So we're going to do a quick around the table and have each of them tell us a little bit about their organization and their mission and goal regarding viral hepatitis in their community. So we'll start with Kate, then we'll have Maggie, and then Sabrina.
Thank you so much, Ivory. Hi, everyone. I'm Kate Moraris. I'm the Deputy Director of Public Health at the Hepatitis B Foundation. So we're a national nonprofit organization based in the US, but we actually do a lot of projects internationally as well. We just celebrated our 30th anniversary. We were founded, and we always say it's a love story. So Tim and Joan were the founders of our organization 30 years ago when Joan was diagnosed with chronic hepatitis B infection. Tim was actually, he's a scientist, so he's a researcher, and was doing research on the herpes virus, I believe. So when Joan was diagnosed, he made it his mission to find a cure for hepatitis B, and he's been working on hepatitis B cure research ever since. And they developed the foundation, out of their home because she had nowhere to turn to for information or resources about hepatitis B at that time. So that is essentially the focus, and what we are most proud of is that we are helping people who are living with hepatitis B get them the information that they need for their families and their caretakers. We also have a research arm, and we're working to find a cure for hepatitis B and doing liver cancer research. We also support and conduct hepatitis B. We also promote awareness around hepatitis B and support prevention and treatment initiatives, serving highly impacted communities, including for chronic hepatitis B infection, as you saw in Dr. Patel's slide, Asian Americans, Native Hawaiian, Pacific Islanders, and African immigrant communities, among others. Our hepatitis B consultation helpline is one of our key programs where we are able to provide the information to people around the world. We answer about 10,000 consults a year by phone, email, social media, direct messages from around the US and around the world. We often hear from people who are recently diagnosed or their family members or caretakers who are concerned about an exposure, for example. Many of the issues that are raised during our consults also inform our work, including the development of educational materials, the development of our public health programs, our public health research, as well as our policy and advocacy priorities. So this leads us to our Hep United Coalition. It's a national coalition that we lead with a partner organization. We are in about 50 states, and it's a coalition that we've formed of organizations that have been working around the country, kind of with providing them with a place to share best practices and strategies in order to increase hepatitis B testing, vaccination, linkage to care. The coalition has a reach of over 1,000 local partners working in 23 states and 30 cities to address hepatitis B related health inequities. This coalition has also kind of served as our grassroots advocacy platform. Over the years, our policy and advocacy is essentially related to improving hepatitis B related policies at the state and national level. We are working to increase funding for viral hepatitis programs at HHS and NIH, including funding for prevention programs and funding for hepatitis B and liver cancer research. We are looking at policies to improve access to care related to hepatitis B services, including improving adult hepatitis B vaccination coverage. And also, we're looking at improving treatment access as well, making sure that hepatitis B drugs are affordable. What's different for hepatitis B is that we don't have a cure, as I mentioned, compared to hepatitis C, and we're working towards that. But if you are chronically infected, that means taking a pill a day, and that can be quite costly for people who are living with chronic Hep B infection. And finally, we're also working to combat hepatitis B related stigma and discrimination. So I'll stop there, and thank you for the opportunity to share more about our organization.
Thank you, Kate. Maggie?
Sure, tough act to follow. My name is Maggie Beiser, and I'm an adult nurse practitioner at Boston Healthcare for the Homeless program. BHCHP is one of the oldest and largest healthcare for the homeless programs in the country, and we serve about 11,000 patients a year across about 30 sites. So we provide care to people in shelter-based clinics, street-based, van-based care, as well as some sort of more traditional community health center type settings. And I came to this work as a general primary care provider and an HIV specialist as part of our Ryan White program. And just an anecdotal experience and awareness of a very high prevalence of Hep C in our co-infected population. And we had some research from around 2010, 2012, that era, describing a prevalence of actually 23% of our population had Hep C based on claims-based data, as well as some mortality data describing elevated, disproportionate impact of liver-related death among particularly men who are homeless and served by our program compared to age-matched controls in the state here in Massachusetts. So this really, more than 10 times more common prevalence in our population compared to the national population, which is an NHANES-based, a house-based study. And then also this excess morbidity and mortality. And that coincided with the advent of direct-acting antivirals. And so I was given some time and some opportunity to develop a policy and a program. And so we have been providing primary care-based Hep C treatment administered by primary care providers like myself, who are not ID specialists or GI specialists, and integrating Hep C treatment across all of those sites to be able to bring Hep C treatment sort of as close to the patient as humanly possible, really. Our model is really predicated on very intensive support from case managers and nurses, well, one nurse and 2 case managers that provide really dynamic and flexible support for navigation through liver assessment and lab assessment, through insurance, prior authorization, and pharmacy navigation, and then adherence support with at least weekly support for our patients on treatment. So we are a very high touch Hep C program, and we have treated a number of folks since we started that in 2014. We're actually now up over 1,100 people who have started with us. I'm not sure there's anything else I could talk about right without, I know we're going to get into some more questions later, but it has been the total joy of my career, and I love working in this space, and it's really something that I would love. I also teach and support other clinicians to do, and am a huge champion of, treat, not referring, and bringing that to the patient right as close to where they need it as possible.
Fantastic, Maggie. I love that, and especially the passion comes through and how much you love what you do. Sabrina.
Hi, thank you. Hi again. My name is Sabrina Thigpen. I am the Program Director for Public Health Management Corporation, PHMC. PHMC is one of the largest public health organizations in the city of Philadelphia. And under the umbrella is 360 programs, including affiliates, that's under the umbrella of PHMC. One of the programs that I have the pleasure of working with is our Philadelphia Hepatitis Outreach Program, PHOP. It's the 1 out of 2 programs that I do oversee. The Philadelphia Hepatitis Outreach Program, it's a mobile viral hepatitis unit who works in the community high-risk areas, and they educate on viral hepatitis A, B, and C. They screen for hepatitis C, antibody screening, and of course, if that person is positive, they will do a confirmatory right there on the spot. The uniqueness of this mobile unit is that we have a team of street outreach workers. And when I say team, it's 2 to 3 folks that go out in the community every day, engage with a lot of our community members on viral hepatitis, HIV, or communicable diseases in a whole. Build relationships within the community. So to help folks feel safe and to kind of cut some of the judgment and the stigma against not only hepatitis, but HIV and AIDS and drug and alcohol misuse. We work with a high population of transient and homeless population in the surrounding areas in Philadelphia. So it's really a challenge trying to get them to go inside to receive primary care. I'm trying to think a little bit more about PHOP. So PHOP has been around since 2007, if I'm not mistaken. They have been in the surrounding areas doing exactly that, educating on viral hepatitis A, B, and C. I don't know if there's anything else that I can think of that I can share about PHOP. I can go on and on and on, but I know we don't have enough time for that.
No, I love that. That's fantastic. Sabrina, I was just thinking in regards to Dr. Patel, her presentation and talking about the high rate of opioid and the opioid crisis that we've been having over the last few years and what PHOP has done. Have you seen your team of 2 to 3, have you seen more, I guess you say patients or more people in the community with the opioid crisis and then coming back being tested positive for hepatitis C?
Absolutely. PHOP, so pre-COVID, we were we were working with a lot of organizations and have a huge partnership with a lot of community-based organizations. So we typically will go inside, do the education, and screen on spot. Not post COVID, well, during COVID, we are out in the community. So we're doing most of our work outside. And so some of the same folks that we have screened 2 years ago and may have not been positive has definitely, we have definitely found that they are positive now for Hep C. And have been told we have not been testing yet for Hep B. We were hoping to start testing for Hep B, but we have been told many of our folks is also co-infected Hep B as well. So yes, the numbers are larger. We have been working in I'm not sure if you're familiar with this park, but we work in McPherson Park. It's right in Kensington area. And so it's called Needle Park. And so it's a lot of IV drug use there. So yeah, so we may go back within 6 months and find out that they are positive, anybody positive for Hep C.
Ivory, if it's okay, I also wanted to add, Sabrina, I think you and I work in probably very similar environments. And one of the things that I think we've made a much more aggressive shift into in the last couple of years is trying to really look at this as drug user health as a whole. And because we have an outbreak of HIV among people who inject drugs and are homeless in our area, 100% of these new individuals diagnosed with HIV are Hep C positive. And also we have we really stepped up our efforts around PrEP and just really frequent screening. And so we actually developed one, we're doing phlebotomy in the field, but two, rather than finger stick testing, but we've developed sort of a smart set to put all of these things together, including your Hep A and your Hep B titers as well, and integrating sort of HIV prevention and PrEP, Hep C prevention and treatment, and HIV diagnosis and treatment sort of all together. I think we are seeing so much. You cannot you can't look at anything in a silo. It all goes together.
Yeah. I don't believe that you can work with one. It's not just one particular population. So you have to touch base on everything. So we touch base on homelessness. We're talking about all communicable diseases. Just more prevention work. So we're focusing more on prevention versus just sticking to Hep C or Hep B or HIV. However, it's really building relationships within the community. Folks are comfortable with us. They see us out there every day. I just had a conversation with Ivory yesterday. She called and I was out in the field. So I make it my business to go out in the field as well. And so we have our community members are really comfortable with us because it's no more of the days where they're going to come to you. You have to go to them. If you're expecting any changes, you have to go where they are. And so that's what we take pride in doing.
And how you develop the relationships and the trust.
Yes.
Yeah.
That's absolutely important. Kate, can you let us know, what do you find are 3 struggles your organization has had in raising awareness or educating and treating your particular the community that you reach out to?
Yeah, I think we touched on that a little bit too. One of them most definitely is overcoming hepatitis B related stigma and discrimination. We often find there's a lot of self-stigma as well to overcome. There is, culturally tied stigma, and then a lot of misinformation and myths and misperceptions about hepatitis B and how it's transmitted. So, we hear stories of how families will separate, not have meals with a family member because they're infected. Or a lot of times in the African community, we hear that they have been shunned from the community. And oftentimes this mostly happens in Africa, but that kind of myth is very pervasive. And it impacts testing. It impacts finding out that you have it, wanting to know that you have it. And then there's also, preventative health practices too, just not going to the doctor until you feel sick. not accessing preventive services. Also, we hear from a lot of communities, so that's kind of a barrier to testing. And then we also, I think there's just limited resources for community-based organizations. There's limited resources in general for viral hepatitis in the US. So we're all working to improve that. And it's very sad considering the staggering epidemic that we're facing in the US. And so I think that's a huge thing. There's a lack of capacity and resources to conduct testing. Oftentimes for hepatitis B in particular, we're not testing in the primary care setting, and it falls on organizations that are smaller to do the testing in the field, to do it at health fairs, and to do the education. And they're pretty scrappy and to find the resources to reach a large number of people. I think those are our main struggles.
Okay. And how do you, and this could be for any of you, how do you combat that? Sadly, there's still a stigma with hepatitis C and hepatitis B. How do you combat that with education and, of course, awareness to, especially with different communities, to really get them to understand how important it is, and to take away the negative ideas that they have in regards to hepatitis B and C? And that could be for any of you, Kate, Maggie, Sabrina, Dr. Patel.
I believe one of, I'm not sure about combating, but we have just out in the fields many stigmas. You're talking about drug and alcohol. So in our case, many of our folks they're blaming drug and alcohols for the reason why they're positive for whether it's Hep B or Hep C or HIV. Because they know typically it's related, IV drug use. And so it's a challenge. For us, it's just more that empowerment and just trying to empower them and to, it takes a lot of discussions, right? Just to, you cannot beat yourself down for something that have happened. What can we do to just work on these conditions? So we usually have a whole list of things that we have to work on, right? And before we even start talking about Hep C treatment or talk about Hep B, we usually have to just do some empowerment sessions, do some building up their confidence.
And I think that also goes back to, and Kate, you can go right after, that goes back to what you guys were talking about with the trust. I think once you really build that relationship within the community and build that trust where they're able to, really say, okay, I understand what Maggie is presenting to me and the information. Maybe what I had previously wasn't correct, but I built this relationship with her, and I feel that I can trust her and the people at her center, where it could potentially take a few months or a couple of years, right. and hopefully they become people who can then go out and really explain to others, oh no, this is right. A little bit more about hepatitis C or hepatitis B.
Many of it is word of mouth as well. So it takes one person to give wrong information, and then you'll have a whole community believe in this same information. And just for example, we work closely with, so PHMC has 5 federally qualified health centers. And we work really close when we are referring we don't necessarily have to refer to a PHMC clinic, but we do. It's easier for us because we know someone, so there again, it's the building a relationship externally, internally. We just had someone just last week, a young couple who came HIV positive, Hep C, Crohn's disease, herpes, and syphilis. I haven't heard of syphilis in so long, so I was a little surprised of that. So we had to find services. This couple did not live in Philadelphia, they lived in Delaware, but of course they were coming to Philadelphia. Many folks will migrate to North Philadelphia for drug use. Long story short, we was trying to find services in Delaware, we couldn't. One of the problems and why they wasn't going to treatment, I mean, they, of course, both of them had felt sick in the past, but they wasn't sure really what it was. These were newly diagnosed, and they were newly diagnosed with everything at one time. But I guess what was so troubling when he said that he was at the hospital and he was about to, he heard one of the physicians say that he was one big infection. So by, and the first thing he thought of to call me and said, I can't believe that the doctor called me one big infection. And I'm not even quite sure that he knew whether it was a doctor or somebody, somebody definitely that worked in the hospital. But that will deter them from wanting to go back to the hospital or to be seen. So we intentionally build relationships with these clinics and hospitals and build personal relationships with folks. So when I do refer, I can honestly say, I know Irie, who works over in this clinic, and, because I know that Irie is going to take care of you. Those are some of the challenges that we see on a day-to-day basis.
And Dr. Patel and Kate had something to say as well.
Yeah, I was just going to I think Sabrina can address it, to say that provider bias is such a huge thing, especially with drug user health. And I think just what Maggie had mentioned, just looking holistically and addressing it as drug user health and doing that provider education, I think is necessary, within the healthcare system, outside of the folks that are already doing the work in the field. And just with providers, with hepatitis B, I think it's also making sure that you're seeing someone that's comfortable, that, that's culturally responsive, that maybe speaks your language, goes a long way as well. A lot of our partners are at FQHCs that universally screen everyone that walks in the door because they know they're highly impacted, and they're coming to see doctors that they trust and feel comfortable with. And just in terms of combating stigma, personal stories go a long way. Just sharing your personal experience and testimonies are effective in the policy space, as well as in general, getting other people to know that you're not alone. We have a Just Be storytelling program, and it took a while for us to really get applications in. So over 5 years now, we have 40 people, and it's just been the most popular and part. And we always have sessions at our summit, and that is the one session where you're hearing real stories rather than hearing the educational talks. That always has an impact on the attendees.
I think what everyone is speaking about is so salient and important. I really appreciate you sharing the importance of that building that trust in those relationships. Obviously, CDC is functioning at a very different level, and our goals are really to support what you all are doing on the front lines. One thing that I think can be helpful is the shift to universal screening, for example, as opposed to risk-based screening, so that you circumvent those biases in some cases, or the reluctance that some individuals may have about disclosing risk factors and behaviors and the kind of reaction that it might result in. And so that's one way in which we think we can move towards sort of judgment-free care. The other is there's a lot of effort by CDC and other federal agencies to really increase awareness around the importance of harm reduction approaches and embrace harm reduction strategies and really promote them. And I think that the more that we as a society can normalize harm reduction and view it as a public health function, the better off we will be and the less stigma that individuals will have to deal with.
If it's okay, I'd also like to just add, and I totally agree with what everybody has said, and just Dr. Patel, to add to what you were saying in Boston, and the dichotomy of drug use around the country is really broad, but here we have a lot of fentanyl, almost entirely adulterated fentanyl, opioid product, as well as crystal methamphetamine stimulant use. So where people were injecting drugs maybe 2 or 3 times a day 5 or 10 years ago, it's now more like over 10 times a day. And so we just purely don't have enough supplies to make it safe for every injection. And so these bloodborne illnesses are just so easily transmitted, unfortunately. And then just to add, interestingly, in our population, Hep C is so prevalent. People tell us that they feel very comfortable discussing their status with other people, that they disclose their status if they are in a position to maybe share a cooker or a cotton or a water, but that most people don't care. That there's an attitude that, if we all have it and we've got way bigger fish to fry right now, like why try to avoid that aspect of things? And that's obviously not universally the case, but people are coming from such a place of danger, like lack of safety, chaos. They're dealing with such high priorities, survival priorities, that often it's hard to ask people to prioritize Hep C treatment as well. And say, this is curable, and curing you now when your liver is healthy is actually great. It's going to be wonderful for you. And this is how we should talk about reinfection prevention. And people in my community are very familiar with cirrhosis and very scared of that. That is a very big deal in their mind. But for our young folks who are injecting drugs, it doesn't feel like an immediate concern. And so I think there's fear, there's also complacency happening kind of in the same space at the same time.
And that's an interesting point. I know when I used to do education in Philadelphia, in particular high-risk populations, what was very interesting to me when you talk about cirrhosis was that they saw that as 2 different diseases. There was hepatitis C, and then there was cirrhosis. They didn't realize that one could lead to the other. And that it was a liver disease. They thought it was totally something different. And so I know, with the CDC support and help, and what all of you are doing and so many other organizations, again, that education is so important. And to be able to, I think that is probably one of the first steps, is the education, and then building trust, and then empowering the communities to really take it forward and to go out there and educate others, like you guys said, to make sure that is really, truly important, because sometimes you think that you're educating people on liver disease as a whole, but then you realize you really have to break it down, that they do not understand all that there is to liver disease, and that these are particular diseases are all connected potentially, that they can progress. And particularly with high-risk populations in some of the communities that we are serving. Now, how can we encourage healthcare providers to be more sensitive to populations affected by HCV through IV drug use? I know, like Sabrina and Maggie, you all kind of mentioned building a relationship not just with the community, but with the doctors in the medical field. But how can we really get them to encourage them to be more sensitive? Like Sabrina, you said, the patient, he believes potentially was a doctor who said what he said. That's not great, for a medical professional to say that in front of a patient, and now they feel either intimidated or they don't feel comfortable now going to that particular person. And at times, it's not the person, it's the position. So now it's just medical professionals and doctors on a whole.
I don't really have an answer for that. You can't teach people to be nice, right? Certain things you just shouldn't say to people, whether it's, talking about Hep C or drug misuse. I believe that you must be transparent. So you have to be really, really clear. And I think that you need to be upfront and intentionally tell folks their risks and their behaviors, and these are some of the effects. However, I don't know if it just appeared that someone was just mocking them versus trying to help them. And so that, I don't really have an answer for niceness. And I think that's why I, have my team here deliberately go out and check out different, organizations before we refer. I never refer unless I know who I'm referring to. I just don't refer just because you say that you're doing, you're providing the service. And that's just for that, because we definitely will fall back on us. When you send someone, they're saying, they're not really looking, this is a whole different organization, really has nothing to do with, PHOP or PHMC. They're just looking, this is where, Sabrina sent me to. And the other thing is, I believe even sending someone to healthcare, it has to be a collaboration in that healthcare. So it shouldn't fall on one person in terms of building that relationship with that, patient or, participant. It should not fall on one. When you walk in my door, everybody is working with you, and everyone is treating you with kindness and respect. And, I honestly, I can't, it baffles me every time I hear a story of someone being mistreated, whether, because they're homeless or whatever the case may be. It's really sad. And I don't know, I think that's something that should have been taught at home before they started in the field.
I just want to jump in because I definitely have thought a lot about this. And I think the answers are, you make it easy, you take barriers away, and you let people share the joy in it. Like electronic medical record prompts, just tell people they have to do it. Make it a red thing on a medical record, just screen, it's in there, do it. Take away prior authorization requirements. Do not make people spend hours of administrative time trying to get something. We took PAs, they're still required in Massachusetts, hopefully not for that much longer, but PAs have been dropped in 8 states already. We've had these incredibly effective, very safe medications for 7 years now. It's time. We're not going to get to elimination unless we make this easier. So you've got to take that out of the clinical space. You've hopefully get rid of them altogether. And you give really clear algorithms and clear guidelines on how to do it right, which we have and exist. And you get to spread the love around. Like, curing somebody of Hep C is one of the most satisfying things we get to do. Can't do that with a lot of other conditions. And patients are so motivated around it. They are so proud of themselves. The provider gets to feel, it's just such a good relationship building opportunity. In our program, we started off with just me doing treatment and then me and 2 docs. And now we have 12 providers across all of these sites who either treat their own patients or we refer other patients to them because they're in family shelters out of town, or they are on the van, or so, they even coming to our main site as a barrier. So we just spread our treatment out. But I think it's systems oriented. And some people will, they're the early adopters, or the people who are never going to want to do it, and we don't want to deal with them anyway. But we got to make the middle folks, we got to make it easier for them and share the joy, because primary care is hard and exhausting, and people are burnt out. But this is a really important thing to be doing. And our job is to when I sit down and someone has 18 health issues we need to talk about, it's my job to bring that bring Hep C from the back burner to the front burner alongside everything else. If I don't do it, they're not necessarily going to do it. And there's such a power dynamic, and it's up to us to do it, but you have to make it easy and make it routine and make it fun.
I think for PHOP, we have such an advantage because we're not a billable service. So everyone that walks in the store, we're grant funding, which is not good because grants come and go. However, fortunately, we're still around. But we don't. It appears that folks are just rushing because it's like it's you have to bill and you have so many other things that you have to do just to take care of this one person. And where we have the advantage that we don't have to worry about this. So we do have that little extra time to do certain things that typically, if you go into a clinic, it's no one there with the time to embed, for every little thing. So yeah, I just believe that it's just a challenge. So it's easy, of course I say, it's building relationships, but then, you're thinking about, what's time, someone come in, a doctor has 15 minutes or 20 minutes, I don't know the timing, but you don't have as much time to work with one person. So you need your team support to support you, to help you. You have 10 other patients that you're waiting for, and you have to keep moving. So everything is a rush. And I think that's where it's just such an unfortunate.
Agree. Wow, I think we could go on for another hour with this conversation, but it is 3:54, and so we only have a few minutes left. So I'm going to quickly ask each of you to give one piece of advice for other community organizers who are on this webinar that you can provide. We'll start with Maggie, then we'll go to Sabrina, then Kate, and then finally Dr. Patel.
Holy moly. Why do I have to go first? I am really thank you for inviting me to a national stage and being able to speak with these wonderful colleagues doing this work. And I think when we are, for those of us who are sort of in the community, working close to the ground, doing the direct patient care, it's up to us to figure out how to make it work for our folks, and then also to share our experience. In whatever venue possible, research, panels, articles, whatever. Like, we need to get the word out in any way, shape, or form, and to prove that our folks can do this. We can be incredibly successful. We're going to get, this is the only way we're going to get to elimination, and our better patients are going to have better health and better well-being and feel better, taken care of, and that's our job, I think. Thanks so much for having me.
No, absolutely. And if you'd like to put your email address in the chat, someone's asking for a little assistance from you. That'd be great. Sabrina?
My mic went out, so I couldn't hear you. Can you repeat? What was the question?
Oh, absolutely. I was asking each person to provide one piece of advice that they can give to the other community organizers who are on the webinar.
I would say just stay in touch and build collaborations and build relationships to share information. I believe, obviously, we're in two different cities, and we share some of the same, challenges. So I think the more that we talk about it, we will be able to, it will be very helpful. We'll be able to combat on Hep C.
Thank you. Kate?
Leverage your resources, leverage other public health priorities. COVID, people are very aware right now of public health, the infrastructure and everything, and getting your vaccines and boosters. So for Hep B, now's the time to get your Hep B vaccine too. And I'll add another one if it's okay. Get loud for those working in the field. Just to add some advocacy in there. That's the only way. We need a bigger viral hepatitis community voice out there.
No, you're absolutely correct about that. Dr. Patel.
So I can't give advice, but I can offer encouragement. Please keep doing what you're doing. The work that you do is so incredibly important, and it's really instrumental to turning the tide on the viral hepatitis epidemic. So thank you for everything that you do. We are interested in supporting your efforts however we can and facilitating the work that you do. We want to hear about your successes and your challenges. So thank you again for having this forum, and thank you to all of you for all the work that you do to identify and treat hepatitis.
Wow. Thank all of you. Thank you for speaking today and providing so much knowledge and resources and information. We greatly appreciate you participating today with us. And we would love to keep this conversation going for the next hour, right? However, we aren't able to, but we have some phenomenal programs that are upcoming. So you'll be able to hear Maggie speak on myth-busting HCV treatment, demystifying HCV treatment and at-risk populations. I'm registering, so I'll be there, Maggie, hearing all about that. It sounds great. The link for that is in the chat. so that you can register for that. So the link is in the chat, and that will be on January 11th at 12 p.m. And Maggie's email is there, but again, the link to register is in the chat. Next program is Hepatitis B Foundation. They're going to have a program on January 20th, and the link for this program to register also in the chat. A conversation with CDC partners. That sounds fantastic. Again, I'll be registering for that as well, Kate. So those are two upcoming programs to kind of, continue the conversation. We can't continue the conversation today, but this conversation must continue and go forward. And it's great to see that we have two amazing programs that are happening in January. And the American Liver Foundation will also be having a program on January 13th in regards to health disparities in regards to medical professionals. And so we look forward to all of these programs that are upcoming. We thank you guys. We have some resources. Please make sure you are following us on our website, liverfoundation.org, as well as our national helpline, 1-800-GO-LIVER, always go liver, and following us on our social media accounts. Again, we just want to thank everyone. Have a safe and healthy holiday season. Thank you all.